Okay, so we should be being joined by our friends over at Facebook right now. We are streaming.
Lisa, are you there? Okay, we seem to have lost Lisa momentarily. I'm sure she'll be back shortly. Welcome to the Big-Hearted Warriors Unite, Orlando AdventHealth. Here she's coming back. I'll let her continue.
Okay, everybody. Hi, I'm back. I don't know what happened. I just disappeared because that's the kind of thing it is. Whoop. And now I'm feeding double on Facebook. So give me 1 second to go over there and cut that stream. And now that's done. Okay, my excuse for this evening, everybody, is I've just tested COVID positive and I have 101 fever and I'm not feeling well. So please excuse any technical difficulties, and we're just blaming it on COVID like we blamed everything for the past 2 years on COVID. But tonight it's impacting the Big-Hearted Warrior Tour. Good evening, everybody. Sorry about the glitch. We are streaming on Facebook and we are also live in the webinar. If you would like to join us in the webinar, by all means, you can still go to the HCMA website and sign up and come into the webinar. We will not be fielding questions from Facebook this evening. We will only be fielding questions through the webinar. So if you have any questions and you are in the webinar, please don't use the chat feature. Please use the Q&A feature located on the directory at the bottom of your Zoom screen. I'm sure most of you are familiar with Zooms by now. This is a webinar, not a meeting, so it functions a little bit differently. Tonight, I am happy to present the AdventHealth Orlando program, obviously in Florida. And we're going to be meeting their team. But before we do that, I want to introduce you to members of the HCMA team who are here this evening. We have Amy Mann, our meeting coordinator, who will be taking the duty of fielding questions as soon as I'm done with my brief talk today, because I'm not going to last the whole night. And Julie Russo, our volunteer coordinator, will be here as well, helping with technical issues and assisting you with anything you need to know about volunteerism in the HCMA. I'm going to stop my screen share now and hope I don't leave you all again. Marcos Hazday. I met Marcos, goodness, about 15 years ago now, I think. He called the HCMA office and said he was interested in treating patients with HCM in Orlando, and I was thrilled to have him on our team. And the program has done so well and grown so much over the time that we've worked together, and I'm really happy to bring you this presentation tonight. Marcos, can you introduce us to your team, please?
Yes, thank you, Lisa, for this opportunity. The members of our team are Dr. George Monir, an electrophysiologist. They are a participant in the collaboration of managing these patients. Dr. Kevin Akula, thoracic surgeon, is an integral part of our team, and expert in myectomy and preservation of the mitral valve or replacement. And then we have Naveen, Dr. Navin Bellam, who is advanced heart failure, member of our team for that subset of patients that need heart transplant. And we have our nurse coordinator, Debbie Moore, who assists us in navigating these patients to get adequate care.
Fantastic. So I'm going to jump onto my slides real quick and kind of walk you through a couple of things. I'm going to be honest and tell you that my typical slides that I would have presented are on my office computer, and I was leaving the house today. So this is going to be a little bit different from some of the slides that you've seen before. So that's our, let's figure out how I am, there we go. So this is just a little bit of a recap of what we've been doing for the past now 26 years. We have the agenda for tonight where we are going to discuss the different clinical presentations of congestive heart failure in HCM, atrial fibrillation options, the attractive differences of septal myectomy or not, HCM Heart Transplant Pathway, which is something that, I've personally dealt with, as has Amy, and how to get in contact with this particular center. There'll be some information there, and then we'll do a Q&A panel. So for those of you who might be new to HCMA, I figured it would be a good opportunity to just give a little bit of a history. I'm not going to read everything on the slide here, but I'm going to tell you that we've been doing our work since 1996. We are a nonprofit 501c3 organization. We were founded in New Jersey. And yes, it was a personal tragedy that led to the creation of the HCMA, which was the loss of my sister Lori at the age of 36. So we took a bad situation and a tragic outcome, and we turned it into a beacon of hope for patients literally worldwide. It is our mission to provide support, advocacy, and education to patients, families, the medical community, and the public about HCM, and support development of treatments, which we have some exciting news about that we're going to be sharing tonight. So if you want to learn more about the HCMA and our objectives and our mission, you can visit the website at forthcm.org to learn more. So I've been giving this talk lately to give some perspective to where we were and where we are at the HCMA now. So in 1996, there was about roughly 300 million people in the United States. There was about 200,000 healthcare providers, 30,000 cardiologists, and 5 programs that had specialized treatment programs for those with HCM, which we now refer to as centers of excellence. So if you're going to start a nonprofit organization to try to raise awareness, you think you might want to go out into the community and start talking about it. But if we had done that, where were people going to go to get care? Because the care system was not well established. So we took that pyramid and we turned it upside down, and we built the pyramid from the top down. And we built our Center of Excellence programming, which now houses over 50,000 patients in our 44, soon to be 45 programs around the United States. And that's indicated by our Center of Excellence logo up here. We've created new programs to help educate healthcare professionals, cardiologists, in partnership with other organizations and on standalone projects where the HCMA has taken a lead, such as HCM Academy, which Amy is the coordinator of that program as well. Then we went out to the community, and now we're starting to do work on legislative initiatives to help identify the undiagnosed, which you see on the bottom here, the Hcm Act, which I'll talk about in a little bit. So in 26 years, we became a little organization who learned how to use this thing called the internet, to an organization that has many different pathways of programming to assist patients, physicians, and the interested public to learn more about hypertrophic cardiomyopathy. So we work in about 3 different areas. I could break them down smaller, but generally speaking, we want to provide support and education to the diagnosed family, those at risk, healthcare professionals, and we want to make sure people not only understand what some of the symptoms and the physical attributes of HCM are. We want to make sure people understand the significant burden HCM places on families and patients in terms of their mental health and their stamina and their overall happiness and well-being. So it's a little complicated to try to teach people about, but we're doing our very best through efforts like our patient-focused drug development meeting and our Voice of the Patient report. Through public awareness and advocacy, we want to make sure that the diagnosed people are getting the care that they need, and those who are at risk are getting evaluated. And that means we have to work with a lot of healthcare professionals to ensure that they understand how to find HCM and how to diagnose it. And we take every opportunity possible. Even when I had to go to urgent care today and there was a PA who said, hypertrophic cardiomyopathy, I think I've learned about that. I said, you need to go to HCM Academy. So I'm recruiting wherever I go. So who knows, maybe we'll get them to join it. Additionally, we work in the space of engagement, and that means we want to engage all of our stakeholders. It's not just what the office of the HCMA says or just what our board says. It's all of our partners working together to treat the diagnosed patient, to find the at-risk, to raise awareness and education throughout multiple programs. So if you want to learn more, please visit the website and you can learn more about that. So if you are a patient with HCM and you are new to the HCMA, or maybe you've been diagnosed for a long period of time, but maybe you need a little bit of help focusing your interest as to what do you need to talk to your healthcare providers about. We have a system that we've been working for about 25 years. We have an intake process, and you can go right on our website and schedule with an intake coordinator. We have Sabrina pictured here. Julie also does intake coordination, so she can assist you. One's on the East Coast, one's on the West Coast. these intake coordinators will provide you with an opportunity to share some information so that we can help you navigate the next step of your HCM care. So we do navigation calls on Tuesdays and Wednesdays, and there's a little video box here with Ross and I play acting. Ross is our project manager. So we're playing for PCNA, which is the Preventative Nurses Association. They asked us to show them what that was. So we created a video for them to show them what a navigation call looks like, which I start almost everyone off by saying, I'm not a doctor, I'm not a nurse, and I don't play one on TV. I'm a patient advocate, and I'm here to make you the best advocate you can be for yourself and your family. So we start every call that way, and we identify areas where a patient can truly learn how to advocate for themselves based on their individual anatomy, testing, or lack of testing that has been done so that they can identify their risk factors for cardiac arrest, manage their symptoms better, and look at options for whether it's septal reduction therapy, device placement, atrial arrhythmia management. We're going to help guide you there. So we want to meet you where you're most comfortable getting information. So we have a YouTube channel. We have discussion groups led by patients. Right now, first quarter, we did over 300 participants in our discussion groups online. It's a Zoom room, kind of like this, but not a webinar, it's a meeting. The YouTube channel has thousands and thousands of hours of content that you can learn all about HCM from different perspectives. And that's part of the reason we bring you the Bighearted Warrior Tour, so that you're not getting one physician or one institution's perspective on how they manage HCM, but you're seeing how other institutions that you might not be able to get to, or you may want to go to, you can learn about their programs as well, and they're all available on our YouTube channel. There will not be a Tales from the Heart tomorrow morning. I will be sleeping or getting antibody replaced or whatever, monoclonal antibodies tomorrow. So there will not be a podcast tomorrow, but typically on Fridays at about 11 a.m., we run a podcast. Dr. Marty Marin joins me once a month. Steve Amen from the Mayo Clinic and Harry Lever from the Cleveland Clinic join me every other month. And then we have other guest stars and speakers and patients and authors. We've done all kinds of fun stuff on there. So I encourage you to look at where you get your podcasts and listen to some of our podcasts. This just kind of breaks down our service models into different programming. So the HCMA's overall main practices and our patient services are in the first bar. The Center of Excellence are in the second. We currently have 17 applications in-house, which is, I did 3 site visits since the end of March. So you're going to be hearing about some new programs coming up in areas that have previously not been served very well. So we're very happy about that. And now we're working on creating international outreach with partners from around the world, so that it's going to be a little bit different, that we're going to help them identify their patient advocate leads, and we're going to help them navigate what's going on in their country. So if you are not from the United States or Canada, because all right, Canadians are kind of like Americans, but we kind of treat them the same way. So if you're from any place else in the world and are interested in becoming involved or becoming a patient advocate for HCM, please call us. We'll be happy to get you involved. And then the last pillar is that HCM Academy that I mentioned earlier. This is a wonderful opportunity for physicians to learn about what HCM is, how to diagnose it, when to refer up, when to keep the patient in-house. And we encourage all healthcare providers to take a few moments, sign up for HCM Academy. It's 6 online courses, and then there's an in-person learning experience that they can sign up for, or multiples if they so choose. So this is our current map. You see that there's some areas that are very blank. I'm happy to say so some of those pink dots will be turning to red dots soon, and some of those gray dots will be turning to pink dots soon. So we're moving people along the process. We need more programs because people need physicians where they live. It's really hard for a lot of people to get on an airplane and go to a center. We know, we hear you, but it takes time to develop. So support from the community is appreciated as we build out these programs. And typically, people want to share their information. Like, what was your experience with a particular doctor or institution? Please call the HCMA office and share those experiences with us. And you will be having an opportunity probably next year to be participating in survey situations where you can share your feedback on a regular basis. And then we'll be giving those reports off to the centers so that everybody can be working at the top of their game. This is a partnership. We all want to be better than we were yesterday. And someday we'll be perfect. Tomorrow's not looking so good because perfection takes a long time to develop. But we are trying to get it better and have more services available. We are working on an exciting initiative, and we are just probably a few hours away from having our first bill number presented. We are working on what we're calling 3 Clicks to Save a Life, the HCM Act. No, it doesn't stand for Hypertrophic Cardiomyopathy. It stands for the Healthy Cardiac Monitoring Act. And this initiative will allow the well child examination in your state to include cardiac components, which it currently only does in the state of New Jersey. And we want everybody's child to have an opportunity to share their family heart health history and their own symptoms with their chosen healthcare provider in the context of that well child visit. We are also improving student athlete participation physicals and communication about who is at risk. We know that asthma, mitral valve prolapse, anxiety, depression, and murmurs are common misdiagnoses associated with HCM before people get their final diagnosis of a true HCM. So we want to make sure that while we're building out this initiative to include the American Heart Association 14-point screening for heart disease in all well child exams, we want to make sure that we're providing education to the physicians doing those examinations as to what the disease states are that they're looking for. It's not just HCM, it's dilated cardiomyopathy, ARVC, arrhythmogenic right ventricular dysplasia, channelopathies, Marfan syndrome, any cardiac disease that could impact a young person or family. Most of them are genetic. Some of them could be acquired, like myocarditis, et cetera. But we want to make sure everybody has an opportunity to have those discussions with their healthcare provider. Now, the exciting news, and I had a bigger slide on this one. So Camzyos is here. Camzyos is here. Mavacamten hit the market. We have an FDA approved drug for the very first time ever in hypertrophic cardiomyopathy. It has been a long haul to get here. We started working with MyoKardia back in around 2013 to begin their opportunity to understand what HCM patients dealt with. This was the focus of our patient-focused drug development meeting, our ICER review. Now we're moving into payer education to ensure that all patients have access to get to try mavacamten if they so choose. If you want to learn more about it, I'm not going to do a lot of slides on it tonight, but you can go straight to the HCMA website and learn about it. There are patient assistance programs for the traditionally insured market, so Blue Cross, Blue Shield, Cigna, et cetera. There are $10 copay assist card for the actual drug, and it is a very unique label. And that means on the label, it says you need to have an echocardiogram at weeks 4, 8, and 12, and then quarterly throughout the use of the drug at this time. There is a copay assistance card for those extra echoes as well available to you. And this morning I had a meeting, even though I really wasn't feeling great, with Health Well Foundation, I always say it backwards, who is a private foundation. We'll be posting their information on our website. It's on the Facebook group right now, but they will offer up to $10,000 to pay for copays and premiums for if any patient being prescribed Camzyos. So we now have a bridge for the Medicare population. There are programs available for Medicaid. There are programs available for private insureds now. So if you have obstructive symptomatic hypertrophic cardiomyopathy and you want to try something before you meet a surgeon or an interventional cardiologist, this might be an opportunity for you. Before anybody asks me, there will be trials in non-obstructed coming up later in the year. They're not there yet. We don't have enough data to say it actually works in the non-obstructive population. So you will be hearing about opportunities to participate in clinical trials. I will pause there. One other comment, we are working with Celltrion, who has a drug trial. I posted it on Facebook yesterday. They're looking at a drug that's very similar to Norpace CR or disopyramide. And they're looking for a couple of trial participants, as is Imbria, who is looking for non-obstructed symptomatic patients for a clinical trial. You can get all of that information from our website. I'm really glad that I got through this without a massive coughing fit. And I am going to turn off my camera. I will be here, but I'm going to go lay down on the couch and listen to you guys do this meeting. And I know I'm going to leave you in fantastic hands as Amy is going to take over coordinating. I am going to launch the poll because Amy's going to remind me to launch the poll. See, Amy, I did it. If you are joining us online, please take the poll to let us know where you're from. I'm going to hand over co-hosting, make a co-host to Amy. And Amy, you should now see the poll thing on the bottom.
I do.
Yay. Marcos Hazday, thank you so much for joining us this evening. And I am going to hand over the evening to you. And I am going to go with my laptop on the couch and turn off my camera. Thank you.
Thank you, Lisa. I'd like to thank all the participants. And I was given the task to talk about congestive heart failure, such a overwhelming diagnosis for some patients, and which includes a lot of symptoms and findings and different subsets. The group I will be talking to this evening is the patient that has non-obstructive hypertrophic cardiomyopathy. Most patients with non-obstructive hypertrophic cardiomyopathy are asymptomatic. If you take the large cohort of patients with hypertrophic cardiomyopathy, 2/3 have obstruction, either evident at rest or with provocation. The other third of the patients are the non-obstructive one. It is important, hence, to define first what is congestive heart failure, and second, how do we get to differentiate between the obstructive and the non-obstructive. I'd like to take a second to define congestive heart failure, because when a patient is given that diagnosis, it can be overwhelming. The best definition of heart failure that I have heard throughout the years is congestive heart failure is defined as the inability of the ventricles to either fill or empty or both. And that is a nice definition because it really involves the patients with, you may have heard, systolic heart failure or diastolic heart failure. I mentioned that in the obstructive group, which is not the group I'm going to be talking to tonight, the pathways and algorithms of treatment are well defined with regards to septal reduction therapy, surgically, and when appropriate, alcohol septal ablation. The group that we are talking about tonight is a group that is symptomatic with a non-obstructive hypertrophic cardiomyopathy, defined by the absence of gradient during echocardiography and or a stress echocardiography. Hence the importance of doing the evaluation with the echocardiogram and the stress echocardiogram. In our center, we quickly, on the initial evaluation of a referral, we quickly define whether the patient is obstructive or non-obstructive, and then apply therapies. The next few slides are direct clinical presentations that I have had during the last 12 to 14 months. It comes straight out of that. And I chose these 14 patients or so because they blend well with the rest of the panels. The most common presenting symptom of the patient with congestive heart failure is shortness of breath, but they also can have fatigue. Other times the patient has difficulty laying supine, or they may wake up at nighttime and short of breath. One of the patients that we have referred to our advanced heart failure team developed actually right heart failure as well. And those patients present with increased abdominal girth, which is sometimes described as ascites, or they may have lower extremity edema. When we have a patient with congestive heart failure, it's very important to define quickly if the patient has preserved systolic function or if the congestive heart failure is secondary to diastolic dysfunction, as as the treatment is significantly different. The asymptomatic patient requires no treatment. When we identify the patient with systolic heart failure, we have algorithms and treatments to decrease the congestion and block the neurohormonal activation that occurs in patients with this disorder. In the patient with diastolic dysfunction, until recently, we really did not have a medication directed towards that. Certainly, we have to use diuretics in this group. It's something that we don't tend to use too much in the patient with hypertrophic obstructive cardiomyopathy, as low volume in those patients makes the situation worse. But we do use diuretics here. We use the term to decrease the preload, which just basically decrease the congestion. And we also utilize beta blockers to allow more filling time by causing bradycardia. Certainly, new promising therapies are here already. It's very possible that mavacamten may be helpful in patients with diastolic dysfunction, and that's yet to be proved. But we already have evidence that serum glucose transporters 2 inhibitors are helpful in diastolic dysfunction. For the systolic heart failure, we do have a large amount of evidence, beginning with the early trials when I was a cardiology fellow. The first trials, some of them in which Dr. Parker or Dr. Brownwald were participants, used the most simple of all, ACE inhibitors. The initial trials included captopril and enalapril. Since then, we have developed a wealth of medications, which most recently you may have heard, usually at dinner time and at advertisement on TV about Entresto. There is also the use of beta blockers. When I was a cardiology fellow, and that was not that long ago, we used to think that if a person came in with congestive heart failure and they were on the beta blockers, such as Inderal, that was a very, very bad idea. Only later on multiple very elegant trials, which many of them were designed by Dr. Parker, we proved that carvedilol improved not only the ejection fraction, but the survival of those patients. And finally, in trials that were designed by Dr. Bertram Pitts, aldosterone receptor blocker, the most simple of them, a totally inexpensive medication, spironolactone, is added to patients with advanced heart failure. In African Americans, in our population with systolic heart failure, I tend to use hydralazine and nitrates. I have been influenced by those results, and in patients with renal dysfunction, which have contraindications to ACE inhibitors or ARNI or ARB2 receptor blockers, we can also use hydralazine and nitrates. It's very important to identify the triggers of the decompensation. In addition to non-compliance to medications and sometimes dietary indiscretions, sometimes things that we don't think of, such as taking a leaf or some of these medications over-the-counter non-steroidal anti-inflammatory drugs, they may block the effect of our heart failure medications, worsen the situation. But one of them that is really, really important, and in this, I get a lot of cooperation from Dr. Monir, is the patient that has diastolic dysfunction with a very non-compliant left ventricle without obstruction that is doing well until he gets atrial fibrillation. In those patients, Dr. Monir may talk. We have antiarrhythmics. None of the antiarrhythmics are great. So at the beginning, especially on the patient with paroxysmal atrial fibrillation, we may decide to treat aggressively early on with radiofrequency ablation. Other triggers that we have found in the last patients in my cohort with congestive heart failure are patients with severe mitral insufficiency, and it's very rewarding that mitral insufficiency can be a target, even in patients with the clinical presentation of end-stage heart failure with obstruction. That subset, we have approached the management by treating the mitral insufficiency with good results. Another very satisfying outcome in the patients that I'm referring to with advanced congestive heart failures are patients with a left bundle branch block, either because they develop the left bundle branch block surgically or as part of the progression of this disease. We find that patients with a left bundle branch block with a very wide QRS and evidence of asynchrony on our echo or dysynchrony, they do respond remarkably well to the cardiac resynchronization therapy. And there are times that we have delayed the need for heart transplantation or avoided at all by resynchronizing the heart. Of course, other options are treatments to restore sinus rhythm when possible. Recently, we had that experience on a patient that had atrial fibrillation and a left bundle branch block. So we attacked both by resynchronizing the heart and converting to sinus rhythm with remarkable improvement in his functional capacity from New York Heart Association Class 3, which means that the patient was short of breath with minimal activity, to New York Heart Association Class 2 and being able to have a normal quality of life. When the patient is at end stage, cardiopulmonary stress testing to document the oxygen consumption, the peak oxygen consumption, is used as a tool to stratify the patient that will benefit from advanced heart failure therapies, of which Dr. Navin Bellam will be talking about. And usually patients who have an MPO2 less than 14 milliliters per kilogram per minute are selected to be evaluated for heart transplantation, together with some other measurements of hemodynamics. We have had success in the last 16 months of transplanting 2 of our patients here with HCM, one with a combined heart and liver with very satisfactory results. Patients with HCM that get transplanted have a very good prognosis, even better, perhaps because they may be younger than other patients that get transplanted from other etiologies. And with that, I will close and pass on the baton to Dr. Monir.
Hello, everyone. I'm just going to share my screen.
Dr. Monir, while we're waiting, is it okay if we just make a couple little comments about Dr. Hazday's talk while we're getting ready for you?
Sure.
So we didn't actually have any questions that came up, but I just wanted to remind everybody that if you have any questions about a talk, you can type it in the Q&A box. And I just want to say, Dr. Hazday, that was a really comprehensive talk, because heart failure and HCM is very complicated. And as myself, I went through heart failure with preserved ejection fraction. So I appreciate just the explanation and going through how it's very different and the treatment's very different. And it's often not recognized. And a lot of patients with HCM, have heart failure with preserved ejection fraction. And I was just curious, would you say that you see in HCM patients more of that, or do you see patients with reduced ejection fraction more when it comes to end stage?
No, I think that I see more patients with congestive heart in this subset of patients. I see more patients with congestive heart failure with preserved systolic function than a patient with end stage. Dr. Maron has defined end stage in hypertrophic cardiomyopathy as an left ventricular ejection fraction less than 50. Usually, people don't think that in the other cardiomyopathies that we have, such as ischemic or non-ischemic cardiomyopathy, Usually we don't define them until the ejection fraction is 40 or 35. There is a trend in the field of congestive heart failure not to even define it by the ejection fraction. But Amy, you're right. There are so many patients that because they have a normal systolic function, the doctors may say, the non-specialist may say, well, you don't have congestive heart failure. You have a good systolic function. And often they don't think that diastolic dysfunction is such a big contributing factor to their symptoms.
Yeah, that's something I live. So I appreciate that. And it's good to know that there are some treatments on the horizon, because when I went through it, I transplanted in 2018, there really were no treatments for, heart failure with preserved ejection fraction. So I just wanted to make that comment, and that was a really great explanation. And let's move right on, and let's hear George talk about atrial fibrillation and treatment options.
Hello, everyone. I'm excited to be here in the meeting with you to discuss few aspects about atrial fibrillation, especially pertaining to HCM patients. So before I start about treatment modality, just quick word about what's atrial fibrillation. If we look at the slide here on the left side, normal rhythm starts from the sinus node, propagate to the bottom chamber of the heart to create one contraction from the top chamber, followed by one contraction from the ventricle, the bottom chamber. In atrial fibrillation, multiple wavelet chaotic rhythm in the top chamber, where the rate can be anywhere between 300 to 500 beats, and controlled only by the central node, how many of those will make it to the bottom chamber, and most likely can create significant heart rate increase. And not only the increase in the heart rate, now there is loss of the synchrony between the top and bottom chamber, and this can contribute to a lot of symptoms. So where all those wavelet or electric impulse comes from, thanks to a scientist from France who discovered that they start from the pulmonary veins, which are the veins joining from the lungs to the heart. They trigger the atrial fibrillation, and now the two top chamber of the heart become chaotic. And that's important because when we come to the management, especially with ablation, that knowledge is very helpful. So why atrial fibrillation can be a problem? In general, not everyone who get atrial fibrillation feel racing of the heart. Some, they can have symptoms different than a palpitation, as shortness of breath, tired, fatigue, loss of stamina, in addition to the stroke risk associated with atrial fibrillation, which is very important in HCM patients. And the last one is progression or leading to heart failure, the one Dr. Hazday was talking about. So not all the atrial fibrillation is the same. For us as electrophysiologists, we like to see everyone in the first stage, paroxysmal AFib. If you think about stages, it's like any disease process. You go from one stage to the fourth stage, it is usually not a good sign. So paroxysmal AFib is when atrial fibrillation comes and stops spontaneously with episodes not longer than 7 days. Once it is longer than 7 days, it indicates now we have more pathology in the atrium than just triggers from the pulmonary veins. If someone remains constant in AFib for over a year, we call it long-standing persistent AFib. And if they have been in AFib for a few years, we declare it as permanent, with really little can be done at that stage. So our favorite one is when we act on the disease early on, where the outcome would become significantly better. So if we look at HCM patients, they are unique when it comes to atrial fibrillation. The atrium size, left atrium, it is actually increased. If we look at the average left atrial diameter in patients with sinus rhythm compared to HCM, they are definitely larger. The cause of the left atrial enlargement is multifactorial. One of them is the diastolic dysfunction Dr. Hazday was talking about, which has increased pressure of the left atrium, sometimes primary atrial myopathy or disease of the atrium itself, the mitral regurgitation, and the important one is atrial fibrillation. We say atrial fibrillation begets atrial fibrillation. When someone starts to have AFib, the majority of patients continue to progress and get worse. So in HCM patients, the prevalence of AFib is 4 to 6-fold higher than the general population. And if we look at all of them, 18 to 28% of HCM will suffer from atrial fibrillation. That's why there is a screening recommendation recommended by both American College of Cardiology and European Society of Cardiology. The most important is once anyone with HCM get diagnosed with atrial fibrillation, they should be treated with anticoagulation regardless of any other risk factors. Just the presence of HCM and development of AFib indicate anticoagulation to decrease the risk of stroke. Despite of all those negative things, over the last 20 years, with the improvement of recognition, early treatment of AFib, we have seen significant improvement in the impact of AFib on HCM patients. And this slide will explain that. If we look between 2001 to currently, heart failure or worsening of heart failure due to AFib have reduced about 4 to 5-fold. The risk for stroke has decreased about 3.5-folds, and the risk of mortality related to AFib and HCM have decreased 11-fold, thanks to the advance of treatment, which we'll be talking about. So if we look at different strategy, this is a busy slide, but I tried to compact it in one. In some patients, if they don't have symptoms and they are doing well with AFib, or if we try to correct it back to sinus rhythm, it doesn't work, we may leave it as a rate control, meaning keeping them in AFib, control the rate. But majority of HCM patients, they usually are symptomatic. Medication we use varies between amiodarone, which is, I tell my patients, very safe on the heart, but not on the rest of the body, a lot of side effects. Others depend on the clinical situation. The advancement of radiofrequency ablation over the last 20 years made it actually a very good option for patients of AFib and definitely for HCM patients. So patients who are symptomatic and failed medical therapy, we proceed with an ablation. As I mentioned early on, and I will show you in some slides, what's the impact of waiting and damage for the atrium and how do we deal with that. So definitely the earlier the treatment, the better the outcome, especially when we target AFib in the paroxysmal stage. So here is an MRI. We do it before we do an ablation. This is looking at from the back at the left atrium, showing the pulmonary veins we talk about. So this will be the left side, top vein, bottom vein, and this is the left side. And this is a normal size atrium. We love it when we see that kind of normal size. Usually there's not that much pathology. So we take that slide, and during the EP study, we create a 3-dimension mapping. This is the atrium, and the one in red are the pulmonary veins. And the color here has a meaning. The healthy myocardium is depicted by voltage in the purple color. When the myocardium starts to be replaced with the scar tissue, it turns into red, the other extreme. In the veins, definitely there's not that much muscle except very small sleeve. That's why they are red. So this is what we see when we have this one. The initial goal with paroxysmal to ablate between the veins and the heart to prevent the trigger from causing the heart to go into AFib. And this will be great because the success rate is very good in that stage. And this is what happened. We ablate here. This looking at the back of the heart, those are ablation lesions, and simply we are done, and the trigger from the pulmonary vein cannot induce AFib anymore. This is a picture from the front of the heart, also showing the ablation lesions. If we allow, this picture is an extreme. It's a patient I have recently done We look how small the veins are because everything is occupied by huge heart, dilated, and this is an atrial appendage. Is almost probably 3-4 times the normal size. And when we see that, usually the outcome is not that great. And I'll show you what happened with this. When we map to look at voltage, it looked like this. Very few areas of healthy myocardium, very patchy in between. And we have during the ablation, not only isolate the veins, we have to target many of those areas because any of those can create a short electric circuit or rotors or arrhythmia we deal with called atrial tachycardia. And I'll show you an example. So here is a video showing the myocardium itself, how the heart is like patchy, very small areas. The only healthy part is the appendage itself, but the rest of it, anything other than purple, is a diseased myocardium with scar tissue. And it makes the ablation procedure longer, more likely for redo, and more likely for other arrhythmias to occur. I'll show you the challenging part of the arrhythmias here after we finish the ablation, and it shows you that arrhythmias which can occur. So we look here, this is electric impulse propagation on the heart coming from this focus. And we map the entire heart to find that little focus, and we have to be very precise to find it. Takes a long time. And this patient, we finished with 4 of those. We finished with 1, and this is the second one, comes from different area. And again, look at the propagation of the impulse, and we have to map. So those, after the initial ablation, they come back for redo because of those areas of tachycardia related to scar tissue. So in conclusion, I want to leave you with some few points. Atrial fibrillation is the most common sustained arrhythmia in HCM patients, and actually a major component of the clinical profile and history. As I mentioned, 18 to 28% of patients of HCM will have will develop atrial fibrillation. Thanks to the advance in therapy and anticoagulation, mortality risk is relatively low, although the paroxysmal events can impair quality of life. Good news, control is achievable by drugs or catheter ablation or surgical. So when patients need to go for myectomy, the ablation can be done at the same time. And with the advent of the anticoagulation, the novel ones, embolic strokes actually have significantly decreased and it become very manageable. And remember, early evaluation and treatment improve outcomes in atrial fibrillation. Thank you so much for your attention, and I'll stop sharing my screen.
Well, thank you, George, for that very nice presentation. Our next panelist is Dr. Kevin Akula.
Can I just, sorry, can I, before we move on, there's just a few questions from our audience for Dr. George Monir. Is it okay if we just take a moment to address a couple of questions?
Yes, please.
Okay. So one of our questions is, how many ablations are recommended before ruling it out as a treatment?
So actually, as long as we have a good target or we don't reach a stage where the entire atrium is scar tissue, there's patients who may need 1, 2, or we come back to the significantly enlarged atrium. Those usually need more than that. So some patients, we come to a point where we say, really, it's futile beyond this point. But now with the advance of technology and mapping system, I don't see a limit of number, but usually 2 or 3 will be the limit for before we say, yeah, this may not work anymore.
Okay, great. Another quick question is, you're talking about mapping. Actually, looking at this question, this is probably not relevant. We can talk about this one at the end. The following question, I am not actually sure if this relates to atrial fibrillation, but there is a question about,
It does.
okay, a drug called, thank you, Lisa,
Multac.
Multac, yeah. Is that a better treatment than other medications for AFib?
So everyone there's different, actually multiple different things we have to look into to choose the antiarrhythmic. Not all of them are okay to use for everyone. Someone has a defibrillator who may be more lenient with some drugs we don't use with others. Multac tend to be relatively safer, but usually not that effective as something as amiodarone. So depending on the stage of the AFib, kidney functions, having defibrillator or not, we choose the kind of drug depending on the clinical situation.
Amy, I'm going to just jump on top of that for a moment from the non-videoed girl here. When Multac hit the market, there was a lot of hope that it was going to be the treatment for atrial fibrillation across the board. It didn't hold out to be true. It's an option for some, but we have found that most patients don't tolerate it well, or it doesn't work very well, but it's worth a try for some, because for a small percentage, it is actually very, very helpful in the long term. And we all had greater hopes that it would be a much more beneficial product, but doesn't work so good long term.
Okay, thank you so much. And so now we'll move on to Dr. Kevin Akula, who's talking about attractive differences of septal myectomy or not.
Great, thank you, Lisa and Amy, for inviting us to participate in this webinar. I just want to compliment not only the team, but how this has been developed, and your support and assistance as we are continuing our efforts with this. Rick, I don't believe those are the correct slides. So let's go. What I'm going to talk about is surgical considerations, strategies, and options. I'm going to ask Rick Morrow, also our active echographer who participates in our multidisciplinary meeting. I'm sorry for some of the background noise. I'm actually at the airport on the way to one of our national meetings, which I have to be at in the morning. So I apologize for any interruption. So from a surgical perspective, what is HCM? We look at this. Dr. Monir gave a very nice talk on arrhythmogenic circumstances associated with HCM, but and then also Marcus Hazday gave a really nice introduction to some of the things that we discussed before surgery. But when it comes down to a mechanical problem within the heart, where there's excessive ventricular muscle creating obstruction of the flow of blood either into but also out of the heart muscle cavity, and effects on the mitral valve function. So the surgical indications and considerations are all dependent upon the patient's anatomy, as well as other arrhythmogenic and valvular issues which have been discussed before. Variations of abnormal ventricular anatomy occur, whether it's septal or isolated papillary muscle contribution, as well as valvular implications, whether the valve can be preserved, which is our preference, and requires replacement. So some of the surgical indications, which studies indicate a need for surgical treatment of HCM. We oftentimes obviously start with an echo. We get MRIs as well as CT scans, and heart catheterization is also imperative. Variations of left ventricular anatomy occur, and we're going to go over some of those very briefly. Subvalvular, which is isolated, mid-ventricular, apical, or global ventricular hypertrophy. Also, some of the symptoms, which has already been discussed, with shortness of breath or dyspnea on exertion, but also dizziness. And one of the most alarming symptoms, of course, is a fainting or syncopal episode. Also, all of these things are unresponsive at this point from a surgical perspective to medical therapies because of the outflow tract phenomenon. So we're going to look at some of the ventricular anatomy. I apologize for the slides. These are not my slides. But the normal anatomy demonstrates the consistency within the ventricle itself, a nice consistent ventricle. And subvalvular is where there is muscular growth within the upper portion of the ventricle, right below the aortic valve. Or midventricular, where the muscular prominence is in the midventricle. Also, this inhibits not only outflow from the ventricle to the aortic valve, but also inflow into the left ventricle, as well as an apical portion of the ventricle having the hypertrophy. So all of these variations can be present in various patients. Oftentimes they're isolated, but there can be a combination of that as well. So let's talk a little bit about the normal anatomy. This is the aorta, the aortic valve. And also one of the most important things that we always discuss is the interventricular septum. The left atrium and the mitral valve are shown here, but most importantly, the left ventricular outflow tract, which is the circumstance that becomes affected by all of these circumstances within the ventricular cavity itself. So this shows some examples of Hcm. This is apical. On the right side, you'll see a normal ventricle, nice dilatation and good global contractility. On the left side, advance the slide, please. This demonstrates the area that's thickened and not only has an inability to contract adequately, but the ventricle doesn't fill adequately as well. Next slide, please. So this demonstrates, click again, please, the midventricular area of the ventricle. On the left, you can see there's dye utilized within the echo.
Kevin, it's Lisa. Can you move your hand from your microphone? You keep losing the audio. And I
Okay.
think you might be covering it.
Yeah, I'm sorry. Yeah, these
That's
are
okay.
these are not my slides as well. I'm kind of filling in here.
Thanks.
The midventricular area demonstrates that there's contractility within the midventricular portion of the area of the ventricle, which not only inhibits outflow tract obstruction, but also inflow tract and filling of the ventricle. Again, normal on the right side, you can see the difference. Next slide, please. These are examples of Hcm with global left ventricular dysfunction. You can see on both sides of this area that the entire ventricle is thickened and hypertrophic. And again, comparing that to the video on the right side. So the mitral valve was discussed by Dr. Hazday, can also be involved. If you can visualize, go ahead and play the echo, please. Okay, so these aren't playing. Just go back, please. There you go. Okay, so if this was contracting, you'd see that this area here becomes very narrowed because of the mitral valve and the presence of the mitral valve creating an outflow tract obstruction. You can see this is, I'm sorry, these aren't playing, but this is the mitral valve, which is demonstrating systolic anterior motion, which is also causing a ventricular outflow tract obstruction. So we're going to present a case of a patient who we presented in our multidisciplinary meeting and elected to proceed with surgery. This is a 61-year-old female. She had significant coronary artery disease, had had a previous percutaneous intervention 20 years ago, had hypertension, chronic obstructive pulmonary disease or lung disease, gastroesophageal reflux, but also most importantly, a recent unwitnessed syncopal episode. There's not a family history of cardiac death or any other history of hypertrophic cardiomyopathies in the past. The echo revealed a left ventricular outflow tract gradient of 30 millimeters of mercury, as normal is 3 to 5 millimeters of mercury. Significantly, though, the cath demonstrated a inducible gradient.
I think you're covering your microphone again. I'm sorry.
Subvalvular, or the subvalvular obstruction. So this is demonstrating the mitral valve as it opens and closes. And as you can see, the subvalvular presence or prominence of this musculature. So this is a subvalvular hypertrophic cardiomyopathy. And you can see from the flow disturbance out the outflow tract where this gradient is being caused by this obstruction of the valve, as well as in continuation with the flow through the outflow tract and the subvalvular thickening of the muscle. Next slide, please. So intraoperative TE resection, when we see these patients in the operating room and Rick Morrow and his team come in, we look and we measure the depth that we want to obtain, as well as the length down into the ventricle of our perceived or preference to resect the muscle. Next slide. Once these measurements are obtained, it gives us an idea during the operation how much muscle to take, but also more importantly as well, how deep we should go within the septum to create a canal or an outflow tract canal. So go back a slide, please. Go back a slide, please. Go to the next slide, please. So this demonstrates the portion of the septum that was resected. It's approximately almost 2 centimeters long, but more importantly, it's about 1 centimeter in depth or thickness. So what we're trying to create is a canal or a new canal in the outflow tract, which will provide improvement of flow through the outflow tract and decrease the gradient of the heart muscle. Next slide, please. So on the left, you see the pre-myectomy, and you see again the flow disturbance through the outflow tract, as well as you see some disturbance of the mitral valve as well with some mitral insufficiency. Post-myectomy, you can see a canal is made or generated by the resection of the muscle. And we've gone from approximately 1 centimeter opening to approximately 2 centimeters opening. It's oftentimes more dramatic though when you see a 3-dimensional rendition of the echo. If we can go to the next slide. I think if you click it again, please. So you can see with the circle on the left side, this muscular ridge of the subvalvular apparatus, which is almost obscuring the outflow tract. There's less than 1 centimeter that you can see for the blood flow to go out of the heart into the aorta. On the right side, you can see we've created a canal by that muscle resection, which is demonstrated here, which improves the outflow tract approximately 2 centimeters. So this was a very nice resection, I think, to not only relieve the obstruction, but create a good left ventricular outflow tract. So in conclusion, from a surgical standpoint, we look at it's dependent upon the ventricular muscular anatomy. Not only the location, but the thickness of the muscular septum in regards to whether it's subvalvular, midventricular, or apical. And this is dependent upon the status of the mitral valve and its contribution to outflow tract obstruction as well. As we showed in earlier slides, though, I'm sorry they didn't demonstrate this phenomenon very well. The mitral valve can actually be a participant in the obstructive process of the left ventricular outflow tract. But all of this, I think, defines the importance of a multidisciplinary approach to patients with Hcm. Thank you.
Thank you very much, Kevin. That was really, really interesting. I can't see that we have any specific questions, but I was curious, as now we have a new first-in-class drug that is geared to treat obstruction and Hcm. Is it going to put you out of business? What are your thoughts on that?
Yeah, Amy, that's a huge circumstance in regards to patients that will be treated with this drug, and hopefully will decrease the need for surgical intervention. From a surgical perspective, as I said in some of the opening slides, a lot of this is dependent on the mechanical portion of the left ventricle and the presence of various variations within the ventricle relative to the muscular thickening. So I think that we're all excited about this drug. I know that Dr. Hazday feels that this will certainly be a game changer. As Lisa mentioned earlier, everyone's excited for the possibilities of this. I think that in some circumstances that patients may not get the drug or get it early enough, I think surgery will still have an impact, but hopefully in years to come, less of an impact as we can treat this medically.
Thank you. I mean, I think surgery has always been the gold standard, and it will be interesting to see, as access increases to Camzyos, like if it will make that much of a difference for patients that they no longer require surgery. So I guess it's watch this space.
Amy, in the Explorer trial, 36% of the patients achieved the goal of the primary goal of the trial, and there was a 10% dropout either because the left ventricular function worsened. So there are some considerations to be taken, and hence that indication for the frequent echocardiographic follow-up the patients on mavacamten are going to require. So I think what is great about mavacamten is that in the 42 years that I have been a physician, we have been using essentially the same medications, which were all off-label, never really truly a medication dedicated on a molecular basis for hypertrophic cardiomyopathy. This targeted small molecule that targets the contraction of the heart is very exciting and might be the beginning of many other mechanisms to come to favorably influence the outcome of these patients. So I still think that there are a lot of issues in which surgery is important, sort of like similar to alcohol septal ablation, and when the patient has a very bad valve where the anatomy is not ideal. Certainly it did not replace in our country the need for surgery.
And Marcus, to add to that, I think it really, again, provides the merit of a multidisciplinary group meeting or committee that we go over all the options prior to deciding on anything definitive. And certainly there's exciting times and new things, research on new medications coming out, as you've always said. And but I think it's a multidisciplinary approach because it's oftentimes multifactorial.
Yeah, absolutely.
The voice from above is going to shout in here. I don't think Kevin or any other myectomy surgeons are going to be out on the street anytime soon. I think there's going to be a need for multiple options for patients depending upon their anatomy and the severity of that anatomy. And we still don't know which subsets of HCM are going to really be best treated with medical therapy versus surgical reduction or catheter-based ablation. So I think the surgeons are safe. I think the interventionalists are safe. And I think there's a role for everybody at the table, and it depends on the patient's wants, needs, anatomy. And, then we get into the question of availability and usefulness and how many obstacles are in a person's way to fill a prescription every month. So there's a lot of things that we're working on to try to make it easy for patients to access. But I think some may opt to have a one and done fix and want to meet a surgeon. So Kevin, I think you're good.
Yep.
Lisa, Amy, thank you for including us. Again, I appreciate it.
Well, thank you, Kevin. And our next speaker is Dr. Navin Bellam, who is a member of our advanced heart failure team. He is often a participant in our meetings and has also an interest on cardiac amyloidosis, which he helps me a lot, which is one of the phenocopies of this disease. So without further ado, Dr. Bellam.
Sure. Thanks, Dr. Hazday, as well as everyone, including the, HCM Association, for the opportunity to, give this talk. So in this portion, we've already heard now of a number of different factors related to patients with HCM. the opportunities to treat them, septal reduction therapy, management of atrial fibrillation, which is a frequent problem, as well as the management of heart failure. If we can move on, we'll start to understand that if some of these therapies fail, what can we do about it? First of all, to get to the pathway for heart transplantation, you can imagine a frequent question that I encounter both from colleagues as well as patients is, what are the factors that make up a good transplant candidate? What are some of the factors that alter who with HCM should move on to heart transplantation? And what are some of the modifiable risk factors to avoid heart transplantation? I'm sure I don't have to tell anyone in this group, no one wakes up in the morning hoping to get a heart transplant, but at the same time, there are patients that can start to feel so poorly that they do ask, what can we do to not feel so poorly anymore? So in regards to that, we have to understand a few things about HCM, of course. We know that it can be genetically determined by mutations of many of the sarcomere genes, both recognized as well as unrecognized. I think we know that based on available data, we may only know about 40 or 50% of the available genes, but we also know that depending on whether someone may or may not need a heart transplant can depend on some of those genetic mutations. Depending on the genotype, there can be significant genotypic as well as phenotypic, meaning how patients actually present and feel, variation that leads to some of these clinical manifestations. Which we've already touched on are some of the common symptoms that can lead to the pathway of heart transplantation. Some of those common symptoms are often heart failure symptoms, chest pain, arrhythmia. Heart failure can lead across the gamut, and I think Dr. Hazday touched on a few of those symptoms in the beginning: shortness of breath, fatigue, palpitations, which could be atrial or other types of ventricular or atrial arrhythmias. Some patients, even because of the degree of heart failure or the change in the filling pressures or the pressures within the heart due to normal or lower ejection fractions, people may have other vague symptoms. Sometimes it can be edema, sometimes it can be trouble sleeping. I've not infrequently heard of patients that may even say they have difficulty with bloating, decreased appetite, changes in diarrhea or constipation because some of that fluid may accumulate in their abdomen. And that may be their manifestation of heart failure. And this is some of the reasons that we, as well as others in the cardiology community, pay close attention to these HCM patients. And as we mentioned already, patients with HCM, they can have increased risks, even irrespective of their heart failure portion of a diagnosis, of both supraventricular as well as ventricular arrhythmias. That's a role that Dr. Hazday as well as Dr. Monir play a close attention and management of, to avoid and hopefully manage that increased risk of sudden cardiac death. Now, one thing I hope can provide a little bit of solace or comfort, though, is even though you have HCM in the audience, it doesn't mean that all patients will need heart transplants or that all patients will immediately progress to heart failure. Less than 5 to 8% based on the available research and data, maybe 10% in some studies, will go on to develop LV dysfunction, which we'll talk about. And overall, over a long period of time, approximately 90% or greater percent of patients with hypertrophic cardiomyopathy will move on to have a fairly benign course. So moving forward, some of the other factors that come into the decision for prognosis and how patients will do. One of them is something we've already touched on, Dr. Akula also spoke about, was the obstructive component. There are different management strategies for obstructive disease versus non-obstructive disease, though it's important to know that both of those patient populations may require advanced heart failure therapies. That can include transplantation in more rare circumstances because of the thickness of the heart, left ventricular assist devices, biventricular assist devices. Furthermore, we're going to talk a little bit about where do some of these patients come from. We spent a little bit of time, but we'll talk further on what are some of the risk factors. And then finally, we'll touch again on what are the pathways to heart transplantation. So breaking it down a little further, we've talked about obstructive disease. When it comes to obstructive hypertrophic cardiomyopathy, rarely do patients go immediately to what we call AHF, or advanced heart failure therapies. As Dr. Hazday, Dr. Monir, as well as others have discussed, Dr. Akula, medical management as well as surgical therapy, beta blockers, calcium channel blockers. On occasion, some of you may have even used Norpace or disopyramide, other therapies to manage the symptoms of a obstructive HCM, where we see the septum or some degree of thickening causing the obstruction, increased gradients. In that patient population that's refractory to medical therapy, ideally, and I agree with Lisa and others, that Dr. Akula will still be very needed by myself and others. 90 to 95% of those patients, based on some of the data that we see, can improve with myectomy plus or minus valve intervention. In centers of excellence, in the hands of a good surgeon, and patients that have, or surgeons that have had good experience and have acceptable numbers and volume of patients where they're seeing this, the mortality is extremely low. And then finally, after all of these efforts have been exhausted, we may still see at that point approximately 5% or slightly higher percentage of what we call non-responders, patients where medical therapy, surgical therapy, valve therapy is still leading to ongoing heart failure symptoms, the shortness of breath, the fatigue, the overall bloating, the ongoing arrhythmias perhaps, that are refractory to all of these treatments. In that patient population, we can start to talk about advanced heart failure therapies. Then in addition, we can see that there are some patients, even without outflow obstruction, where they are the non-obstructive hypertrophic cardiomyopathy population. If we look over a long time frame, some of the data from Marin and Tufts, amongst other places, have shown usually about 1.6, 1 to 2% per year of those patients will go on to progress more advanced heart failure symptoms. In the patients with provocable obstructions, with and without exertion, that's what this is intended to mean, anywhere from 3 to 7% of those patients will progress to heart failure symptoms as well, despite some of the medical therapy. So ideally, some of these patients like yourselves can be managed well for a long time with medications as well as surgery, but there is a subset where we have to keep in mind we may need to consider further advanced options. Moving forward, amongst the non-obstructive population, something that we follow closely, and I know Dr. Hazday and myself speak frequently amongst the patients within our center about, are the patients who have normal LV function versus reduced LV function. And as has been stated in the guidelines, in the hypertrophic cardiomyopathy population, we try to use an ejection fraction of greater than or less than 50% as one of these lines in the sand, if you will. Now, that doesn't mean you can't have symptoms with an EF of greater than 50%. It's rare, but not unheard of, to develop symptoms in the setting of normal LV function. That's where other markers can help us. Degree of atrial or ventricular fibrillation, whether someone has late gadolinium enhancement on what we call MRI, very thick septums or very thick wall thickness throughout the myocardium or heart. These could be risk factors why someone could have symptoms despite a normal, quote unquote, EF. And some of these heart failure symptoms can be related to the diastolic dysfunction. That's what Dr. Hazday talked about in the beginning. Is it due to the ability of the heart to contract or the ability of the heart to even relax in the first place, causing impaired filling and potentially still low output heart failure? On average, when we've looked at these types of patients, non-obstructive, the time period of symptom leading to potential heart failure listing was on average 8 years. And about 1% of those patients with New York Heart Class 3 or 4 patients without obstruction had some of these findings. So it was a very small percentage of patients that had normal ejection fraction, meaning that this is fairly uncommon. And hopefully with ideal medical management, management of the atrial fibrillations, management of the septal reduction therapies, the obstructive components in some of these other patients, we can avoid transplantation. And as we already touched on, the size and thickness, as well as the degree of scarring, if patients at centers of excellence are undergoing cardiac MRI, can obviate some of these risks. Moving on, as we talk about now, let's say we've been managing all of these problems as well as possible. We are entering what we call maybe an end stage or burnt out Hcm. As we said, one of the unifying factors or pieces in the puzzle is, has the ejection fraction really started to drop? And in some patients, or in the hands of some physicians that may not see HCM very frequently, they may say an ejection fraction of 45% really shouldn't be a problem. But in patients with HCM, we now are understanding that even in ejection fractions of less than 50%, it can be not uncommon to start developing symptoms sooner than in patients without HCM. As we said, about 5 to 8% of these patients will progress to end-stage disease. Factors we will look at is the left ventricle or the thickness of the heart starting to thin, which we would not expect in a patient with HCM? Is the EF starting to decline even further than 50%? And in large centers, particularly in some that are seen in the Northeast, they've seen some of these same factors. About 5% of the patients progress. About 50% of the patients ideally remain stable. But as we can see, as time goes on over the years, about 5% per year will slowly progress as that EF starts to drop. And the common things that we also saw at that point, once the ejection fraction starts to drop below 50%, is a very common association with atrial fibrillation. And that's a reason that at our center, someone like Dr. Monir helps very much in trying to prevent the progression of symptoms with atrial fibrillation management. Therefore, moving on again, something else that we can see is what are some of the treatment management options. We'll touch quickly on this as Dr. Hazday already spent a great deal of time. Beta blockers, ACE inhibitors, ARNIs, which is the Entresto he talked about, mineralocorticoid agents, spironolactone, eplerenone, SGLT2 inhibitors. Some of your doctors may have talked to you about things like Farxiga, Jardiance, empagliflozin, or dapagliflozin in certain settings, as well as the role of defibrillators with and without heart failure, as well as the role of cardiac resynchronization. In patients that are treated with some of these therapies, we have seen that ideally some of the severity of LV dysfunction, further decline in the degree of heart failure, can be stabilized quite significantly from some of these 4 to 5 or higher percent per year down to approximately 2% per year. But nonetheless, unfortunately, while this does stave off things, it doesn't always prevent it for everyone. And the risk of mortality, death, worsening symptoms is still tenfold higher in patients with HCM when they have this degree of LV dysfunction and EF that starts to decline versus patients that do not have the LV EF of less than 50%. So what's next? Now we are starting to reach the end stages of HCM, as well as we're reaching the end stage opportunities. We're managing the medical therapy as well as we can. We are considering ICDs, we're considering CRT, we're managing atrial fibrillation or arrhythmias as aggressively as we can. Some of these common associations that I talked about are where we start to ask ourselves, we may not be able to medically manage or procedurally manage these complications any further. Refractory arrhythmias, once the EFs really starts to drop below 35%, the awareness that someone may have very strong pathogenic mutations, that may be a factor. Having lots of scar on the cardiac MRI, tachyarrhythmias for which the ICD is causing more frequent discharges, as well as ongoing significant symptoms despite all of this medical management, really tells us we may have reached a point of no return, unfortunately. So again, moving forward, what are these transplant considerations? Well, as we touched on the prior slide, they're the factors that I mentioned, as well as ongoing New York Heart Classification symptoms refractory to all of these therapies. And New York Heart Class 3 and 4 symptoms are patients that are having fairly frequent symptoms at rest or with minimal exertion. Patients that can not even tolerate at that point eating without feeling bloated, decreased appetite, not being able to even dress themselves or walk outside of the house or do any of their activities of daily living. They can't even go through a grocery store anymore without feeling really fatigued or wiped out by the end of the day. These are patients that are really reaching the end stages and need urgent action. When it comes to further risk stratifying these patients, just like Dr. Hazday touched on, some of the other criteria we look at to objectively identify the degree of heart failure can be the cardiopulmonary stress test, and understanding this is a balance of when patients may be wearing a face mask often, they may either be using a stair stepper in a heart failure setting office, or a bicycle, or a treadmill, or there may be other criteria or options depending on where you live. Patients are wearing these devices and being exerted at heavier and heavier workloads. Maybe the treadmill is going up slowly. The resistance on the bike is increasing as the patient is pedaling, and seeing what is the association of how hard is the heart working versus is someone out of shape, or is someone maybe have lung disease that is causing some of these limitations. And that's how we stratify what is the oxygen consumption of the heart. And we see in patients that have oxygen consumptions on average of less than 14 mils per kilogram per minute of oxygen consumption, or less than 50% of what you would predict for someone of that age. Those are significant risk factors that their degree of heart failure is really progressing, and they may have significantly increased mortality within 1 year. Another factor we may use can be elevated filling pressures or lower cardiac output, cardiac blood flow on invasive hemodynamic studies such as right heart catheterizations, as well as some patients may even need IV medications, or they may need to be frequently hospitalized and constantly on IV diuretics, as Dr. Hazday touched on. Now, something we try to pay close attention to in a heart failure office is some patients may not fit the typical mold. You may say, hey, you know what, your oxygen consumption, or you're doing okay on these stress tests. Well, that could be because patients may be having ongoing arrhythmias at the same time. They may be having ventricular arrhythmias. They may be having inability to tolerate their medications. So in those settings at transplant centers like ourselves, where we see a great number of patients and are now one of the top transplant centers in the country, we may ask, are there reasons to consider exceptions for some of these hypertrophic cardiomyopathy patients? And that's the same reason in rare considerations may be had for left ventricular assist device or total artificial assist devices as alternative surgical options to bridge patients towards a transplant sometimes. So moving further, what is some of the other portions of the transplant evaluation pathway that can be looking at the comorbidities? Hopefully patients have been doing a great job at managing not just their HCM, but also the other factors that could lead to complications. Do they have diabetes? Do they have pulmonary hypertension? Have they had cancer? Are those things factors that may affect their ability to both successfully do well with a transplant as well as live a long time and feel well with a transplant? What is the social support system? You can imagine a transplant is not just a single person undertaking. There are a lot of hands involved, a lot of people involved, and sometimes patients can be really wiped out after a big transplant surgery. They may need people to take them back and forth to appointments. They'll need frequent procedures to make sure that they are not having what we call rejection afterwards. There are medications involved. And for those reasons, psychosocial motivation for how motivated is someone to get a transplant. We have social workers as well as psychiatrists see people routinely. And also sensitization as a result of all the procedures and medications patients have received over their lives. Do they have appropriate levels of what we call antibodies that can be managed so that we can find a good match for a patient? So at the end, we go through this, we evaluate the patient, we have a large multidisciplinary meeting with everyone involved, and we go through a matching process. And then patients end up on what we call a transplant list. And that has changed over the last few years. And of course, things could change at other times, anywhere from status 1 all the way down to a status 7, where patients may not even need to be or are not on a list any further. Frequently, but not always, patients may end up somewhere at a status 4 if they're waiting at home with HCM. You can imagine, depending on how sick a patient is, do they need to be in the hospital? Are they still having ongoing frequent arrhythmias? That place on the list could change depending on how urgent someone needs to be listed, or do they need a heart sooner? That can be a case for a status 1 patient, for example. Afterwards, once ideally someone has a match, you can see there's a number of changes that happen. Some of the medications that they used to be on change completely. We add transplant medications such as tacrolimus, mycophenolate. We monitor levels. Ideally, patients move from an ICU, they recover post-surgically, they move to a regular floor. We talk about rehab and recovery. And then we talk, just like I did a moment ago, about outpatient surveillance, the frequent endomyocardial biopsies and heart catheterizations to look for rejection. We use non-invasive blood tests. We have very frequent follow-up. We see patients 20, 30 times over the course of the first year. We see them more than sometimes their own family does, to make medication adjustments to try and fine-tune these things for our patients. And then moving on finally towards the end, really, outpatient surveillance is a lifelong endeavor. The endomyocardial biopsies may not ever end for some patients, though they become less frequent ideally with time. We use non-invasive blood test markers. And like I said, the clinic follow-up, medication adjustments, frequent echocardiograms, as well as the support system that's needed, becomes something that we see with our patients for life. And whether HCM or not, that can be helpful. One thing that I did not have an opportunity to place on here because of time permitments was, as Dr. Hazday said, in well-selected patients and in patients that have HCM, we have learned that outcomes are overall quite good over a long period of time with thousands of patients in follow-up. That in well-selected patients, when we try to make that balance, we ask ourselves, is a patient more likely to do well over 1 to 5 years with a transplant versus just continuing their medical management? And we have had good success, fortunately, as a program in that regard, as well as based on national data. So thanks again.
Thank you, Naveen. That was really, really interesting and a very thorough description of the transplant process in HCM. So just being myself a transplant patient, I know Lisa is as well, it was very interesting. So it was just really a comment. And I work more on the patient side, and I speak to a lot of patients going through the transplant process. And one thing that I have noticed is that for many patients, it's a very long process of being able to accept it. And I'm wondering if, from your point of view, like at what point you kind of bring up that word, because it's a word, the transplant word is very frightening to us patients. And, you know, some of us kind of go down slowly and some of us kind of go down very quickly. And I'm just wondering what your thoughts are about, you know, how you communicate with your patients, like when, like how you bring it up and interact with them to kind of prepare them for what's to come. And is there a sweet spot? Like, you know, if someone gets to a point where they're too sick, you know, what's your experience with HCM patients?
Sure. So I'll be happy to give my version of the answer. And my answer will be skewed because I am a heart failure cardiologist. And then after that, I'll be happy to have Dr. Hazday give his own perception or way that he describes things. I think when I see patients, which we also do sometimes without significant heart failure components or symptoms, we always talk first about the multidisciplinary approach that we have at our program, as well as managing all of the symptoms related to HCM. However, just like we touched on in the slides, when we see patients are continuing to have symptoms, they are having risk factors and not being managed ideally by medications or continuing to have problems, like I said, atrial fibrillation, ejection fraction that continues to decline, then we really try to get further prognostic assessments. Like I said, I try to get an idea. And actually just earlier this week, I spoke to Dr. Hazday about a mutual patient that we're seeing with an ejection fraction of less than 50%, but overall doing well by her standards. The way that I try to say this at that point is, well, we should get some objective data such as the cardiopulmonary stress test, because some patients may say they're doing well, but we all know, definitions of doing well can be different for different people. Some people have gotten so used to living on their couch that just walking from room to room is a great day. And then some patients will recall days where they used to be able to go on short marathons, and not being able to do that is a definition of poor for them. So when I personally start to see that ejection fractions start to decline, and there is some semblance of abnormality on blood testing or otherwise, that's where I try to use more objective assessments. And at that point, I do try to bring up the idea that we may reach a point where the medical options or procedural options will run out, and we want to find a balance over what is too sick to be considered. Because especially in a lot of these patients, they're usually younger than some of our other transplant patients. And what we also don't want to do is toe a line and wait until someone literally has 1 foot in the grave. And now they don't just have heart failure, they have liver failure, they have renal failure, they can barely talk. That is not a patient that you want to try to move through a transplant surgery. And you can imagine trying to bring them back from that point can be very challenging. So finding that balance is really important. And for those reasons, I try to bring it up when I see these risk factors, but I'd be more than happy to hear what Dr. Hazday sees, because he sees patients, to be honest, ideally a little bit earlier than I see in the majority of our patients.
No, I agree. I agree with everything you say, Naveen. Obviously, we want to intervene before the patient starts declining with cardiorenal syndrome. And I think early, as I do have some electrophysiology training, I also have noticed that as the patient deteriorates, one of the recent referrals that I did for heart transplant is the inability of the ICD to rescue the patient. That's the next section, but it happens. I do tend to put together all the comorbidities that the patient has, what is the quality of life that they had in the past. And it's true when you mentioned that patients do adapt and they do less and less and less. And that is something that I try to gather in the visits, in the clinical history that I take on the follow-up of the patient. The patient that you referred to with a non-obstructive hypertrophic cardiomyopathy, but with the profile of end-stage cardiomyopathy on the fibrosis of her heart, she happens to have had a very wide QRS, and she did respond to the CRT to the point that you probably have not listed her, correct?
That's completely correct. In fact, when I remember we spoke about it, and I said, you know what, she's doing better, and it's worth trying to delay some of these things, because transplant is no free lunch, and it's not a guarantee that you'll live for 100 years with a transplant. So if we can try to avoid it until we absolutely have to exercise those options, my feeling is that's the way we should manage these patients too.
On the other hand, we have
the voice from above here for just a second. So I have a cautionary word to patients who say, but I'm fine.
Mm-hmm.
I was fine until I was really not fine. I knew my ejection fraction had blunted and was hovering in the high 40s, 50 back in 2011. And I was asked, do you want to do a right heart cath and see what your numbers look like? I'm like, why? I'm not going to do anything about them anyway. I'm fine. I'm fine. So I lived in that state of denial for a considerable period of time until I wasn't fine. And by the time I had my first right heart cath, I had almost missed my window. My cardiac index was 1.4. they were asking me, how are you actually even speaking to us right now? I'm like, I do not know, because there was no blood in my system. I was not doing well. So I would urge any patient who has a blunted ejection fraction to get the data and look at those objective measures, as were mentioned, and talk out with their team a strategy. This may be a long game. You may stay in that status and you are okay for a long period of time. I know people 8, 10, 12 years in that state. But statistically speaking, and there was an article from Barry Marin a number of years ago, the indication of a blunted ejection fraction, the time to transplant or death on average was 7 years. I made 6.5 years, and then I was transplanted. So there's something about statistics, but you need to have all your data and you need to have a plan. And while I know the word transplant is frightening and we all want to put it off as long as we possibly can, and I completely agree, you should not try to do it before it's time. If you are well enough, yet sick enough at the same time and time it well, it can be a relatively easy course, but it's not a guarantee. But it's certainly better than the alternative. Thank you, Brandy, my donor. Marcos, did you have any other comments?
No, I was just going to highlight the comment that Amy made. Some patients take a long time to decline, and some others really is for no particular reason that we can identify, decline so fast. We actually, and I have read this in the literature, one of our patients, 32 years old, with end-stage hypertrophic cardiomyopathy, developed severe tracheostomy irritation, and in a matter of months, developed hepatic congestion to the point that he actually required a liver and heart transplant. So the hepatic congestion progressing to cirrhosis could be very fast in some patients, and we had a very satisfactory response to this young man. Thanks God for having been able to get the team to consider him in with such decline in his health, but his age was in his favor and he overcame this. But his was a rapid decline, and I can tell you, because he was not on any of these novel anticoagulants, that he really didn't have any liver disease. It actually took us forever to anticoagulate him with warfarin, and which told me that he, for a long, long time, did not have liver disease. And then all of a sudden, this was a rapid decline.
I mean, I think, you know, speaking to transplant patients or on that pathway, it's a very common theme, and we compensate well when we're younger too. So it's like most people I know at the beginning stages, when they're kind of know they're going down the transplant path, it's mentioned to them, they're kind of like, well, but I'm fine. You know, I was like that too until I wasn't. And I think that, you know, moving forward, and just other medical professionals I've spoken to in the heart transplant world, I think it's really, really important, especially in HCM. And you obviously, there's a vast difference in HCM patients, and there's many, you know, family history I think is important too. You know, a lot of us have family history of, you know, early deaths from heart failure or transplantation. All those things are really important to look at. And I think it's important to introduce it early enough to have a patient, even if they're not anywhere near ready, but they're kind of going down that track, as a possibility. You know, we have a lot of people in our support group who are, you know, it's just it's hard to accept that. It's hard psychologically to think of someone taking out your heart and putting in a new heart, and, you know, from a deceased donor. It's not an easy process to go through. So it's just, you guys are the medical doctors, but there's that whole other side, you know, from a patient perspective. So I just wanted to comment on that. And
Amy, I'm going to jump in from above again. So my fever is going up, not down at this point. So I'm going to be wrapping here soon. But I do want to tell those who are interested in the transplant pathway and the physiology behind it, I will be going, once I'm recovered from COVID, I'll be going down to Texas to meet with Dr. Bill Roberts yet again. And we have, I think, 3 donor hearts, patients who have gone to transplant, who are going to have their hearts sectioned by the eminent Dr. William Roberts, who does this all the time and has been dissecting human hearts for probably 40, 50 years. So I will be down there in June. You'll see the event listed. We will be live, and one of our moderators from our Facebook group, Teresa, will be there with me, Victoria Teresa. And we were actually going to section her heart like I did mine all those years ago, and yours.
Mine.
And yours, yes. And they will live together in a nice little display case. And what I find absolutely fascinating about this process, so A, thanks to Dr. Bill Roberts for sectioning them so well. B, thanks to the University of Toledo Plastinization Program for agreeing to plastinize these hearts for us. But the differences in the anatomies are quite striking. You would think it would all look the same, and it doesn't. It looks very different. Your heart looks different than my heart, than Irene's heart, than Hannah's heart, which was a transplant out of the Orlando program. So they all look very, very different, but it's all the same disease. And there's nothing that quite brings it home than to actually physically look at the heart in your hand. So we will have I think we're going to have 7 of them now, and one of them will be a Danon's disease heart, which is extraordinarily large. So I think if you're fascinated with anatomy like I am, and you want to see all the differences, please tune into that. And I'm going to hand it back to you guys. And we're going to hear from Debora here. Now.
Debora, yeah.
Okay, David.
It's always wonderful to listen to all these doctors that I work with talk about our program. AdventHealth is the only HCM Center of Excellence in Florida, in Central Florida. Our physicians are experienced in looking at all of these different clinical profiles for adults as well as children. And your whole health is our priority. So the best way for us to support your mind, body, and spirit is working together through all of our areas of expertise, as all these doctors talked about, by combining their knowledge of the arrhythmia specialists and the surgeons and the medical geneticists and the imaging specialists and the invasive cardiologists, the transplant physicians, and even the pediatric cardiologists. Together, we provide that treatment with compassion and the effective treatment. As you know, HCM is a genetic condition, and so we also have the ability to identify those family members that are genetically linked to this condition as well, and we can connect them with the appropriate care as well. So I'm the nurse navigator and the contact that you would be reaching out to at our program, and you can reach us phone, fax, web, and also through our email address, and they're on the screen here. So if you have any questions about our program, please feel free to reach out to us. As you know, HCM can be very frustrating and scary, but with the supportive care of all these wonderful physicians that we work with, we hope that we can continue to empower you to feel like you're able to live the life that you love.
Well, thank you, David.
Great. Thank you, Debbie. I think this is about the time. Well, actually, we haven't gone over the poll yet, just to see where people are coming from. So I'm just going to say that 50% are from the Southeast, where you guys are. We've got 50% from the Midwest. What else can we tell you? 100% of the people who answered are patients. Just have a look. We have 100% were diagnosed in the past 2 years. 1 of 2 are on medication, and 1 has an ICD. So, and 1 has experienced atrial fibrillation. Yeah, so that's kind of our stats of who's on live, but this will of course live on Facebook, and it will also go onto YouTube, and it will go onto our website. So there'll be plenty more views. Now is about the time that we are going to take off Facebook Live. So if there's anybody who's on the webinar who would like to ask a question